Thank you for joining. Not sure where to start. We invited Mark to give grand rounds, and after I sent him the invite, I realized that the date would be election day, and I emailed him back and I said, Mark, are you really sure you want to come? Should we look for sometime in the spring? And his classic Mark response was, Z, the show must go on. So here we are. So I've had two marriages to the same woman, but when we married in the States, Mark was a master of ceremony. So he and I go a while back. Mark has been did his undergrad in philosophy. He's both a neurologist and a psychiatrist, and he's really credited in doing some of the early emotion induction imaging studies in our field. He certainly is credited for having gotten TMS to where it is now, for have gotten BNS the way it is now. He's the editor-in-chief for the Brain Stimulation Journal, which many of us aim at publishing in. And he is, above all, one of the most generous mentors I've had. Welcome.
Thank you, Ziad. Thank you all for being here today, for coming out after an interesting night. And I'm delighted to be here. I really am. This morning's meetings with folks really served to lift my mood. So I'm glad to be here. And Z said, talk on whatever I want to talk about. And I chose this title, The Amazing Ongoing Revolution in Brain Stimulation Methods as Treatments and Tools of Discovery. So that's what I want to cover in 60 minutes. Let me tell you how I want to parse it out. Before I do that, this is a CME talk, and so I have to talk about disclosures. I don't think I'm in conflict with any of the things I'll be talking about. I've been blessed with funding from lots of different sources, and they're listed there. I've partnered with industry, but not really jumped into industry economically. I don't own any equity in devices. I'm less and less a paid consultant by choice. And when I say I'll consult without money, people don't listen to me as much anymore. I'm the editor-in-chief of this journal, Brain Stimulation. I'm also the co-chair of an upcoming meeting in Japan I'll talk about. Oh, and there's one more disclosure I have to tell you about. Nobody knows it, but Ziad is actually my brother. Let's see. He's been around throughout my career. This is a picture of a group of us at the very beginning of the first meeting for the OPT-TMS trial, which is one of the pivotal studies in proving that TMS works. There he is off to your far left, I suppose. And then here's another picture. We had a DARPA grant, and we traveled to some island up in Lake Michigan, had to pitch our way. Ziad put on a tie, but he let his hair grow in a weird way and had a goatee that looks a little bit interesting. This is a classic of Ziad. We created the first true double-blind TMS study where we had a TMS coil that was truly blind and blocked, and we had electrical stimulation on the head that would mimic the sensation of TMS, and we had noise dampening ear plugs for the patient and the treater, and there's Ziad wearing his dampening ear pieces. We were funded by NASA to actually put people at bed rest for 6 months and periodically did stimulate their motor cortex to see if maybe we stimulated motor cortex in astronauts over time, they might be able to get up and land on Mars faster. And I'm not sure exactly what the problem was, but you look deep in thought and at least temporarily unable to solve whatever we were doing. Here in a more modern picture, here's Ziad at one of the meetings with other folks from Charleston, Barron Short, and Nolan Williams. And then here's a picture that I have right outside of my office, and it's a Nahas little corner. So there's Ziad. Whenever anybody left our lab, we would have them wear that silly Mexican hat. And in classic Ziad abstract, he did not wear it himself, but he held it over a potential space. And then there are pictures of Ziad's children, both past and present. So anyway, he's not really my brother, but he is the brother I never had, actually. So how do I even give this talk? Well, I'm glad to be here. And I am constantly saying the Niebuhr prayer of God granting me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. The votes are done, the election's done. I cannot change any of that anymore. I can be a good scientist and a good doctor, and I can try to do what we do, that is figure out the brain and how it works and come up with new treatments. And so I need the courage to change the things I can, and I'm going to do that. And I think I'm been able to parse that out. And so I'm just sharing that that's how I'm getting through today and the next few days and the next part of my life. Now, I wanted to talk about have a political joke, and Ziad says, we don't allow political jokes. And I said, why not? He said, too many of them get elected. All right, I won't give you any more jokes. I had several more, but when I rehearsed this talk with my wife, she said, you can only do that one joke, no more. So I'll turn back to what I think I do better than stand-up comedy, that is science. So what I want to convey is an overview of this amazing space of brain stimulation. So in my role as editor, I see 1,200 manuscripts a year. We've just gone through the submissions for this upcoming meeting in Japan, and there were 1,400 posters or oral symposia. And I just am amazed at all the different things that are happening around the space. And there's some commonalities that are happening, but it's just really an explosion of brain science. And I'm really lucky to be here and a part of it all. And so I said, I'd like to give a talk where I just kind of share that amazement, because it is. And so I'm trying to do that in this talk partially. And the reason that Harold and I founded the journal Brain Stimulation, and we fostered these meetings, is this idea of consilience, which is a word I've relearned later in my life, where it means the coming together really of formerly isolated areas of knowledge that then and new themes and new ideas emerge out of. And I think that's actually happening in the brain stimulation space. And so in this talk, I want to kind of show you some of the consilience that's happening, maybe, but at least from what I see. So there is this meeting in Japan. I urge you, it's not that far from Minnesota. Maybe there's a direct flight to Tokyo? Yeah. So anyway, here's the brain stimulation world. That's a Venn diagram. It brings a lot of different people together, neurosurgeons, when they put things in the brain, neuroscientists, trying to figure out how the brain works, neurologists, psychiatrists, obviously, cognitive neuroscientists, and engineering. So these are people that can come together in this space and come up with consilience. So why is all this happening? And this is the real take-home slide that is so important to our field. So this is a cartoon of, a neuron and a synapse and the synaptic cleft. And we all know that with an electrical impulse, the depolarization happens, and then the neurotransmitters are released and they travel across the cleft, get taken up or not. And that's the miracle of neuropsychopharmacology. And I'm a card-carrying neuropsychopharmacologist. I take medicines every day. I write scripts every day. I'm not saying medicines are bad, but if you think about it, what are those neurotransmitters doing? And what they are doing is simply, they're a gating function. They are just deciding whether that electrical impulse from one nerve gets passed on to the next. They're just a rheostat on the wall for the lights. And so if you reduce all of pharmacology to a modifier of electricity, then you realize that electricity is the currency of the brain. And if that's what's important, that's why I'm thinking, that's what you're doing listening. It's really electricity within circuits in your brain. Then that's the fundamental knowledge that allows us to then put electricity back in the brain and do such amazing things. And so this really is the basis of the revolution, is that we are rediscovering the electrochemical nature of the brain. I mean, I learned that on a test as a freshman medical student. I would have said, yeah, it is electrochemical, but I would have heard the chemical and ignored the electrical. And now we understand how important they are. So this is the buffet line, and it gets bigger and more abundant. The feast grows every time I give a talk. And I used to try to cram everything on one slide, and now I've crammed everything on 2 slides, but I've left so much off. And so I'm sorry if I offend you with your new brain stimulation gizmo, but this is the field in front of us. And so I'm going to start with the FDA approved methods. There's ECT, the grandmother of the field, and modifications. Ziad was important in this modification that we're working on called FEAST. There's magnetic seizure therapy, which may be a part of ECT. Then there's transcranial magnetic stimulation, which I will come back to, and it's FDA approved now for depression, smoking cessation, OCD. And then there's putting wires in or on the brain, deep brain stimulation. That's FDA approved for Parkinson's disease, epilepsy, tremor. There's a way to do that responsive called responsive stimulation therapy. There's epidural cortical, and Ziad was really pioneering and doing some of the early studies with that. And then the newest thing that I learned last week, it's now FDA approved for treating glioblastoma multiforme. I'll come back to that one. I learned that one not in my role as journal editor or conference organizer, but as a neighbor. My neighbor across the street, actually, I went to deliver a casserole, and she had this thing on her head. And I said, what is it? She said, well, you must know about this. It's brain stimulation. It's what you do. I'd never heard of it. Anyway, and then there's vagus nerve stimulation. And I'm almost embarrassed to talk about VNS here because there's so much pioneering work going on. But there's invasive cervical, which is approved for epilepsy and depression. There's a modification of the invasive cervical that's approved for stroke rehab. There's non-invasive cervical, where you actually put kind of something looks like a razor and stimulate the vagus nerve in the neck. And I tried to do that on you, right? Yeah, we've tried to do that up in New York very early on. We were looking at heart rate changes. They didn't change. But anyway, that's now FDA approved or for cluster headaches and migraine. And then there's transauricular coming through the ear. You can take any cranial nerve and somebody's stimulating it. And some of those things are actually working their way to FDA approval. Trigeminal nerve stimulation is for opiate withdrawal. And there's a gizmo that you can use at night for treating ADHD, which is FDA approved. Okay, now we're going off the list. These things are not FDA approved, and CME people want me to make sure you understand those things. You could prescribe, they're FDA approved. These things are not available for prescription. So there's TES, which is the parent term for transcranial electrical stimulation under that umbrella. There's TDCS, which is direct current, a constant current. There's TACS, an alternating current. And then there's transcranial random noise, where you put actually noise into the system, which has interesting effects on stochastic resonance and signal changes in the brain. There are TENS units that we use around. They're able to be bought and sold. And some of those were grandfathered into the FDA legislation when it was written. There's a new kid on the block, transcranial pulsed ultrasound, where you can take an ultrasound just like what you use to look at a baby in the womb. And instead of streaming it, which gives you the image, you can pulse it. And that will cause a nerve cell to depolarize. And we figured out ways to get through the skull to actually use ultrasound to get into the brain. There's a lot of interest in ultrasound because you can't walk down a hospital corridor without bumping into ultrasound machines. They're everywhere. They're inexpensive. It's non-invasive. And unlike most of these other technologies, you're able to go both deep in the brain and focal. And so it's potentially the holy grail of this field. There's a lot of interest. There are other very interesting, and there's people who are actually packaging up a medication and putting it in some kind of a spherule of ultrasound sensitive packaging, injecting that into a vein that then goes into the brain, and then using external ultrasound to release that chemical exactly and only where you want it. So there's a way of combining ultrasound with medications to precisely deliver medications, which is very interesting. There's another, I'm getting tired just going through the list. Are you all with me? There's temporal interferometry. And that's where you take a very high frequency stimulation and you pass it here, and then you pass the same stimulation coming from the other side, and let's just choose 1200 hertz. And if we pass those together, they would then hit each other, those waves, and then they would cancel out. But if we cleverly go 1200 over here and 1210 over here, then when they cancel, we'd actually have a wave of 10 hertz at the canceling area. So wow, isn't that cool that we'd be able to actually stimulate deep in the brain with 10 hertz with these competing waveforms? That field has just exploded over the last 5 or 6 years. It was the hot topic, I think, 2 big meetings back, and just more of an eye candy, done more in cells, not really in animals yet, and then it's gone into cells now, and now it's into human trials. And so it does appear to have is a there. It's quite complicated. Then there's additionally optogenetics. Now we'd say, well, optogenetics is never going to get into humans, but that's not happening. That's not true. It's actually starting to get into certain applications. So anything I left off that somebody really wants to shout out and add? Okay, so we're going to go through all of that here. We'll be here for a week or so. I hope you brought sleeping bags and food. Actually, I can't do that. So what I want to try to do is just hit some of the highlights, some of the consilience coming out of the field, and show how ideas are moving across from different brain stimulation methods, which for me is really so interesting. So this is a slide borrowed from Harold Sackheim, just looking at publications as a function of these devices. And you can see TMS is the leader now. DBS is a close second. It's a lot of DBS for the few number of patients implanted, but there's a lot of good work you can do with that. There's TES, ECT, not as much, vagus stimulation, and then TFUS, that's an abbreviation for the ultrasound, transcranial focused ultrasound stimulation. We should probably add temporal interferometry to that as a new emerging line coming up. But anyway, you can see that there's intense interest in science across the fields. So instead of focusing on one method, just having this to talk about TMS, I'm going to talk about these ideas, and they are across the the different methodologies, and where we think about increasing dose and density of dose. There's always the issue with these technologies of how do we find the right target, either for a group or an individual. There's a lot of interest across the technologies in coordinating our stimulation with brain rhythms. So looking at underlying EEG or other ways we capture brain rhythms and synchronizing it. And then the other big theme that I want to talk about is manipulating brain state during and around stimulation. Seems as if Hebb was right, that when we want to go in and change a circuit, activating that circuit always gives us a better effect. Almost always. There's some examples where we did it wrong, but they still had an effect. It just wasn't the therapeutic one. So I'm going to start with TMS, which I know the most about. So how did it all start? And hopefully this won't be too redundant for you, but we'll kind of show you why it took so long to get where we are in one way. It's been around for a while. This is a quote from Linda Carpenter in 2020, that there are 20 million TMS sessions in the US since 2009. I've done some back of the napkin kind of estimates now with data that I've gotten from China and some of the Chinese manufacturers. And I think that there are 1 million people on planet Earth now per year that get remitted from depression with TMS. If you conservatively, if you look at what's going on in the US, Europe, and there, and you look at conservative rates of remission and depression. So that's a big thing. 1 million people every year are getting undepressed with this technology. So how did it get started? Well, with many areas of science, there's not one person. There's a lot of good areas, good people across a planet at a certain time will have a great idea. And that certainly happened with depression. So back in the early 90s, many people had the idea that you could use TMS to treat depression. There was a group in Vienna. There was several groups in Israel. There's Pascual Leon, who was in Spain at the time. My colleague Saxby Pridmore was working on Australia. And then I stumbled on the technology at Queen Square in London and then at the NIH. And some advantages that I had was I started as a neurologist and psychiatrist focused on circuits and behavior. I started doing brain imaging and I was trying to figure out emotion circuits in the brain. So I was obviously interested in the maps and the circuits and how to modify them. I was at Queen Square in 1989. Modern TMS was invented in 1985 in Sheffield, London. And John Rothwell actually took a device from Sheffield to Queen Square because he was afraid to put the device on someone's head because he was afraid that the magnetic coil would zap the brain, kind of like it would a hard drive of a computer. So they actually did it at Queen Square. And then he left behind a machine, and that was the machine that I stumbled onto when I was there as a research fellow. So what luck was that? And then when I went to NIH, they happened to have a machine there, and I was able to do work then. My card as a neurologist helped me integrate with the TMS motor physiologist. So the people who are using it first were investigating. You can use TMS to do a pulse and then cause your thumb to twitch. And they were using it to do the timing and try to figure out motor physiology. And I was able to learn from them and work with them and then steal it for therapeutics, which some of them resisted. So why was I interested in depression? Well, anybody who's seen the magic of ECT knows that you can take someone who's catatonic and with just 8 treatments, sometimes even less, get them totally back. And that is just a remarkable thing if you see it clinically. And so what the heck is going on in the brain to begin with? And then what's happening with ECT? What's the reset that's happening? We were just talking about that walking over. But, you know, even though we still don't understand that, it certainly does work. And the fact that it did work gave me confidence that TMS might. And so anyway, there were these cortical subcortical loops that were being talked about. And my idea then and now is that it's these cortical subcortical loops that are dysfunctional, that are actually the depression. Depression is a disease and dysfunction of these circuits. That was a radical idea back then, but I think it's true. And so I was able to get permission to do some of the first studies. This was the first patient that we did. And then here are the results that came out of the OpTMS trial in 2010, which was, in my mind, the definitive study showing that it worked. In between this study, 1995, and 2010, you can see there were 15 years of wandering in the wilderness, trying to figure out how to make it work, trying to overcome some of the biases, and finally get NIH funding to do this trial. These are results after 6 weeks showing this 30% remission that you can get in treatment-resistant depression, which at that time was better than any medications that we had, thyroid augmentation, lithium augmentation. We didn't have the neuroleptics, I mean, the atypicals or some of the others, but it's still these are the numbers that we still get. So it was FDA approved finally in 2008. The way we did it was 1 treatment a weekday for 6 weeks, so 30 treatments, and used around 10 hertz. Later, another company with a different coil BrainsWay got approval. We got CPT codes, and then there's been steady clinical adoption and industry growth. How many TMS machines are in Minneapolis, St. Paul? 4 clinical sites, each one have 1 machine or a couple of machines?
Yeah.
So it's hard to find a major city in the US now that doesn't have some form of TMS, which it's popular in part because it has no cognitive side effects. It's not a drug, so there's no drug-drug interactions. There's no IVs, restrictions before or after treatment. And back in the day, after we figured out that it would work, we, the people in the field, along with the one industry partner, Neuronetics, had to figure out a way to actually make it palatable and usable by psychiatrists. And back then, maybe now, but back then for sure, many psychiatrists chose psychiatry because they really didn't want to touch patients and they did not want to do procedures. So we had to figure out something that would help educate people who had selected away from this kind of an approach. And so we were able to figure out a chair, a system that allowed us, well, one size fits all that that works. And the great news is that it does work in routine clinical practice, and it works just about as good in routine clinical practice as it does in my hands or Ziad's hands. There's not that huge difference. My friend and colleague and mentor, Harold Sackheim, is now in charge of the Neuronetics, which is a company's database, and they now have 15,000 TRD patients. And so these databases are getting pretty big, and he's mining those and looking at the results. And so this is the data published on 5,000. It's about the same for 15,000 patients, where if you take people with treatment-resistant depression, they've tried and failed 2 medications and talking therapy, you'll get 2/3 of them, about 60% better. That is, they have a response. Their symptoms are cut in half. Of those 2/3 that are better, about half of those people, or 30% of the total, will have remission, which means their depression symptoms are temporarily gone. And that number keeps popping up in all the studies that you look at. And that is a really good number. If you look at the glass half empty, 30% of the people who sit in the chair 30 times are we're missing the mark. We're doing something, and we don't know how to identify those people. So there's still room for improvement. So how do we improve? Well, we can think about the dosing. We can think about different frequencies. We can try to figure out targeting, or the density of stimulation, or brain state during stimulation. This is a summary paper by Kevin Caulfield, a student in our group, is now on faculty. And what he did was he looked at all the different ways of delivering TMS, either conventional, once daily. So can you see right here is what we started with in the initial FDA approval. So we'd have 3,000 pulses a day and 1 treatment a day. There was a minor revolution where a group out of Canada, Bloomberger and colleagues, said we can use a different way of stimulating called theta burst, so a burst pattern, which is a pattern that you would hear if you listen to hippocampal neurons talking to each other. So it's kind of a pattern that is known to exist in the brain and seems to be especially sensitive to causing synaptic changes and plasticity. So if you fire theta burst back into those cells in the hippocampus, you'll get changes. And so if electricity is the currency of the brain, it appears as if most people's brains speak theta burst better than they do 1, 5, 10 hertz burst. But it's much more biologically active and more efficient. So it's faster. So you can get with 600 pulses the near equivalence of what would happen with the old way of 3,000. So it's faster, and you can do that 1 session a day. Or now you can start doing more than 1 treatment a day, and we call those accelerated. And that's what people are doing now. And you can do that either with the old way or the new way theta burst. And so comparing across studies using these different models at the end of the treatment course, this is the Neuronetics study. This is Ziad and my OpTMS trial. both response and remission. Actually, this is the remission rates you can see are lower. And these studies have a bigger remission rates, but they're on medications. So people are staying on their medicines in these trials, whereas in our early studies for scientific purity, we actually had to go medication free. And I think that's the difference here. So I interpret this as saying, well, there's not much of a difference in the overall response or remission between those old studies and now. So that same thing is coming out. So how do we get better? Well, what if we look across total number of sessions or the total number of pulses? And so this is work that Kevin did looking at response rates. And what you can see is in green are the things using that theta bursting pattern. And then in pink are the high frequency, and then blue, the low frequency. You can see people, not a lot of people are using low frequency because it's just slow. You have to 1 hertz, it takes an hour. So to get, or 30 minutes, whatever you're doing. But if you look at the response rate across these studies, you can see that if you increase sessions or you increase pulses, you're more likely to get higher overall response rates. And if you look at this dot here, the real trend leader is this one. It's a theta burst study where they went very high. And the size of these circles is the number of subjects in the trial. So the most effective one is right here. So what's going on there? Well, that's a study by one of my students who's now out at Stanford's, Nolan Williams, where he just said, we're going to go ahead and give 50 sessions within 1 week, 10 sessions a day for 5 days using theta burst. And in that study, he got about 90% remission within 1 week. So this is quite remarkable. Not only was he able to speed things up, not 6 weeks, but 1 week, he was able to actually get out of that 30% remission range to a higher remission bit. And this has been thrown in front of the field or delivered to the field in a good way. However, it's different because he did 3 things at once. He increased the density and the dose. He did precision targeting. I'll come back to that. And he did an adjustment for how deep it took to get into the brain. So those 3 things he threw together all in one trial. So who thinks that it's the increased density and dose that matters? I'm going to raise my hand. See, you might have lost the vote last night, but this is a vote you can participate in and there's no losers. All right, who thinks that it's the precision targeting that really matters? Ooh, okay. And then how about the adjustment for prefrontal depth? Nobody even talks about that. All right, it's clear that there's a scattering here. Nobody wins this election, but so it's really all my fault. My response to the world often is that I get guilty, and so Nolan ran the study by me before he launched it, and he said he was going to do 3 things at once, and I said, Nolan, come on, we're scientists. You don't do 3 things at once. Then we do 1 thing at a time, and then you see whether that matters, and that's how we do science. What you're doing is going to make a mess. And he says, I know, and I want to make a big impact, and then we'll sort it out later. and going back to the Reinhold Niebuhr prayer, it's ready to accept the things we cannot change. I've had teenagers. Sometimes you can't change. And I could not talk Nolan out of that. And he went ahead and did it. And so here we are in the sorting out time. So what about 10 sessions a day? Well, this is my colleague, Dr. Lisa McTague, and she has gotten NARSED funding and the VA funding to do a dose finding study where we try to figure out how many treatments do we need to do in a day. Now, Nolan did 1 treatment every hour, and that's another question. How long between each sessions do you need? And so Lisa did only 30 minutes between each session, but she did a very clever sham control building on Ziad's work, where you could actually take a patient and then switch within the day and give them sometimes real and sometimes fake and keep the patient and the treater blind. So she really had to have that technology of blinding to do that. So and she did effective connectivity targeting, but no depth adjustment. So the way that she did this was she divided people into, let's just see, some people got only 5 active sessions over the entire week. And then some people got 50 active sessions. So you were randomized to some ratio of how many active sessions in a day you would get. And when you do this, you don't have to do 50 in each trial. All you want to do is plot a curve. It's a very clever way to do a dose finding study. And so that is what she did. And what did we find? Well, so this would be the people who only got 1 treatment a day. And then out here where the people got 10 treatments a day. And this is the before versus after mood and anxiety symptoms. And so you can see that these people didn't really budge much. And it was only when you got to about 6 treatments a day that you began to see a big effect. You can see that in the same thing with psychosocial function or mood and anxiety questionnaires. And those effects persisted out to at least 1 month. So her crude answer to this question is only 6 sessions a day and only separated by 30 minutes. And so now you can treat people for just a morning or an afternoon. It's not a whole day affair for them. And who can't take a week off where you spend every morning to get your depression treated? So it really opens up a dissemination in a whole new way. And that's what we're doing in most of our studies now, is this abbreviated bit. Now, you can see it doesn't reach a true asymptote, but it gets you in the ballpark. And so, the question is not fully answered, but at least we know a really important bit. Less than 6 a day, probably not worth it. So these are all the differences between the two. I won't go into all the weeds, but there are other differences. So it's still far from settled. I think this 6 session a day for 5 days will have effects. It's not FDA approved, but I'm greedy. So we've now reduced it down to a week, and a week of just half mornings. Can we go even faster? And that's what we're now funded by DARPA to do. I'll come back to that. What about the distance into the brain? So Ziad was there very early on when we figured out people's motor thresholds, how much electricity it takes in the coil to move your thumb. And, physics matters, right? So it's just distance. And about 60% of the variance between me and Z in terms of our motor threshold would be just the measured distance from here into the brain. The other 40% is fascinating. 20% of it is actually the morphology of how the white matter fiber twist up into the gyrus. Tal Herbsman and you did that. And then the other 20% is pharmacology. So it's very interesting, yeah. But anyway, we found this out. And then we did a study, one of the early studies, where we stimulated just at motor threshold. The FDA was looking over our shoulder. We'd been causing seizures, and they did not want us to go much higher. And so we treated just at motor threshold, and we found effects. People in these little circles were responders. So we got some people better, double-blind study. But look, nobody over age 50 got better. We did this study, and there was another study that came out almost the same time out of Emory, where they found exactly the same results. And I won't say whether 50 is old or not. I mean, looking back behind me, that's actually pretty young. But anyway, why did people 50 years and over not respond to TMS? Well, we had just gone at motor threshold, and we said, well, maybe there's atrophy that's occurring in the brain of constant chronic recurrent treatment-resistant depressed patients over 50. And we then looked at some of our data sets, and sure enough, there was atrophy that was there. And so we then said, well, we need to turn it up. We need to get up and get into the brain. These people didn't get better because we didn't get in the brain. We missed the target. And so we came up with a rule of thumb. That's a joke, a rule of thumb, where we went 120% of motor threshold. And that was what was done in the FDA pivotal studies. And that was what's kind of reified and used in the literature. And until recently, that wasn't examined much, until again, my student, Kevin Caulfield, with E-field modeling, we were able to look in the brain and figure out exactly what 100% of motor threshold will do in a person. And what he did was, in a group of, this is a group of smokers, he did the 100% MT here, and then what would happen with the rule that we had before, 100 per 20%, it's inadequate. The overall activity is less than that for a group level. But if you look at the individuals, you can see that when we go to 120%, some people, it's still way less than what we need, right? This person is still getting inadequate. Actually, in this person, it's almost getting unsafe to go that high. But so 120% didn't work as a group, and it certainly didn't work individually. You can see the variance in terms of what just using some ratio does when you go prefrontally. And so he solved it and said, well, what would we need as a group average in these smokers to get into their brain? And the answer was 133% resting motor threshold on group. But again, on group, look, some people at 133% are still are inadequate. These 3 people would still not get the dose we need. This person would probably have a seizure. And so this just says that we need to be able to figure out how much we're delivering into the brain, and that using E-field adjustment is just the way to go. And perhaps maybe that 1/3 of individuals who don't get better, we're just not reaching their cortex. It's still possible. We need to do E-field modeling. Now, it used to take forever on a computer, and it was hard to do, requires an MRI scan. Now there's systems that are able, if you have a scan, you can almost do it real time. And so you can make these adjustments now in real time. And I think the future of TMS, we were talking about what it's going to be. You would never think about doing it in a sophisticated way without an MR and then knowing if you're in there. Or maybe, and we had this discussion last night, maybe since 2/3 of people get better without this, we would roll out and just do regular TMS. And then those people who are non-responders would then get a scan, and then we'd figure out what we need to do. So in terms of cost effectiveness, when and whether you would do something high tech like MRI and E-field modeling, we'll work it out. But I think we can make it better. The other thing about this, just to have a sanity check, if you had to precisely locate and do an adjustment, there's another technology, these brain sway coils that are out there, and they are big coils that go all over, and they're larger and they're deeper. But so far, at least in clinical practice, they don't seem to be convincingly superior. And so maybe it's not just this issue of distance and location. Oh, we don't know. Okay. What about brain state? Heb was right. The nice thing in psychiatry, we used to have talking therapies and behavior therapies. We had pharmacology. And now we have brain stimulation, psychedelics. But these things are not competitive. And the really cool thing about the future is that brain stimulation, I think, effective will be integrated with all that we've learned about talking and behavioral therapy, and likely with the right combinational pharmacology. I think that those 3 things will be coming together into the psychiatrist. It's no longer a prescription pad. Well, the toolbox that we use in a nice way. They're not competitive. So as I mentioned before, for OCD, for TMS, you have to activate the obsessions before you do the stimulation, or it won't work. For smoking cessation, you have to activate the craving before you do the treatment, or it won't work. And then I'll come back to this. There's this FDA cleared cervical VNS where you have somebody, if they've had a stroke, they'll be reaching for an object, and then you stimulate the vagus when they're doing it correctly. And so precisely manipulating the behavior with the stimulation is crucial for that application as well. So behavior matters. So what about the phase synchronization? Well, let's see, this is the group that's doing it at MUSC in Columbia, Dr. Paul Saja, Truman Brown, the physicist, Robin Goldman over in Wisconsin. And my colleague Ulf Ziemann was one of the pioneers here. And what they showed was that if you stimulate over the motor area and you pulse away, if you look at and you're gathering EEG, that there's a certain spot on the EEG up and down the phase cycle where if you deliver the pulse, you'll get a larger MEP. All right, it just makes sense. If you've got an old car and you're sitting at a gas station at the stoplight and it goes, our brains are that way, kind of up and down, plasticity, excitability, and you can hit the brain at a rising excitability, and you're going to get a bigger effect than if you're going temporarily into an inhibitory state. So they've shown it. This is one of the early studies. It's all over the place now, showing that this phase dependency of motor effects, you can see it in visual system. It's really quite prevalent. And so one of our questions was, does a single pulse of TMS over the prefrontal cortex produce a different effect in the anterior cingulate if it's synchronized with the person's alpha rhythm at that time? So we did TMS, EEG in the scanner. And in this study, we just kind of delivered the TMS regardless of the EEG phase, and then we back correlated bold activity as a function of EEG phase. So we just threw the net and then looked backwards to see the thing. And sure enough, it does matter that depending upon when on the person's alpha phase you fired your pulse, you get a bigger effect, right? Down in the cingulate. So it's here to here. So we found this both in healthy controls and then in a group of depressed patients. So if we're getting a bigger kick to our thing, maybe that has therapeutic effects, So we decided to do a clinical trial. And this is Truman Brown, who helped set it all up. So we took people, we gave them MRIs, we gave them treatments in the old model, 6 weeks, and with assessments. And so in the scan, in the treatment room, they'd be hooked up to EEG. We'd get their EEG, and we would deliver it at their alpha frequency. So if your alpha frequency was 8, you'd get 8 hertz. If you're 12, you're 12 hertz. And then at the beginning of each of the trains, we would record EEG, and then we would have, when you were in the scanner, we would have figured out your correct phase. And then we would start this pulse correctly with the phase. And then we'd go at 10 hertz or whatever your hertz is. And then we would look at the EEG afterwards to look and see if we've gotten entrainment. Have we made the brain march along in the way that we want? And so we do that for every session, every train in every session, 30 sessions. So a lot of EEG matching. And we randomized to 2 groups, either unsynchronized or synchronized. And if you looked at people who got better in the synchronized group as a function of how frequently they were getting entrainment, we sure did see a correlation in that group. Obviously, we didn't see anything there. And we could actually kind of sort out responders versus non-responders by their degree of entrainment. And we didn't see that in the unsync. They weren't being synchronized, obviously. However, unfortunately, if you look at the 2 groups, both groups got better, and we didn't really beat just standard old practice overall. But you could see what was happening going along, and we could begin to see that some of these patients were starting to get better, and then we didn't recalibrate their sync because they had to go back to the scanner, and we didn't have access to the scanner that frequently. So our idea was, if we had just recalibrated, we could have driven all these people into remission. And so we pitched that to DARPA, and they funded us to do that study now. And so we are doing that study now, where we get everybody in the scanner, we figure out their phase, their correct phase, and then we do the same kind of study. And now we're doing it accelerated, 10 treatments a day, 30 minutes off. And in between, we're actually doing very sophisticated CBT, both computerized and then assisted, with the idea that we want to get fast responses, good remission, and with coupling it with CBT, we want to be reinforcing that circuit that we think we're fixing, and that hopefully the CBT will make this effect very durable, right? The combination of the 2. So last week we did our first patient, open label. We're family. I can show you data. And so this is a woman, treatment-resistant depressed for 20 years. And her pre-day PHQ-9s were 20s, For the first day, 21, 13, and then boom, she's remitted by day 4, 5, 6, and her anxiety goes down. So we're very excited. We're doing another one this week. And these are just open label feasibility. We show these to DARPA, and then we hope January they're going to fund us to do a randomized trial to really show whether it works. We will be getting MRI scans along to look at phase changes and then adjusting. And so we'll be able to look at the dynamic changes in these circuits over time and really test this idea. Is that the key? Is that the secret sauce to getting people undepressed with this technology? I'm very excited about that. We were talking about the cost of MRI scanning. All right, how's this going to scale up, Mark? You got to go and live in a scanner. You're going to have EEG. Get out of here. So we're actually doing a side study where we're actually doing FNIRS, infrared spectroscopy, in some of these patients, and trying to see if the FNIRS will give us a poor man's signal that we can correlate to what we find in the MRI scanner. Could we just get 1 or 2 FNIRS electrodes or whatever, and get a signal that we could calculate phase on to make it go. So anyway, there we go. So we're trying to expand access. I'm putting TMS in a van, trying to get it out there. We put TMS in space. I don't know if any of you have heard about this. So when we go to Mars, the biggest problem, not payload, not return, not anything else, is crew depression. It's going to happen. How do we treat it? If you send Prozac, not everybody responds to Prozac. You send several different types of Prozac, but not everybody responds. And by the way, you know, we know nothing about Prozac bioavailability. When you're floating, does your stomach absorb it as much? And also, by the way, it expires in a year. Do we have to keep sending up more Prozac? So I've been pitching to NASA whenever anybody would look, that if they have a solar panel and they could have TMS in space, and then that can treat their whole crew forever, as long as and so I wrote a grant with Donna Roberts, a former NASA engineer, now neuroradiologist. And you know, there are a lot of grants you write, and this is one of the very few that I just laughed when I sent it in and said, they'll never fund this one. And they did. And so we said, as a prelude to that, you have to see whether you could actually do TMS in weightlessness. And so there's this thing called the Vomit Comet, where you can get in it and you go up and you ascend and then you tip over. And then for about 30 seconds, you're floating weightless. And then you do it again. And you do that on and off over 2 hours. And you've got 30 minutes of weightless time, you know. So we designed a way to actually do TMS while you're floating. We had these goofy looking helmets that you could put the TMS coil in. We used Bayesian approaches to be able to figure out the TMS motor threshold with PEST with only 6 pulses in our time. And so what do you think happens when you do it when you're floating? Does your motor threshold, the amount of electricity, require more or less? Votes? More?
Less.
Yeah, our hypothesis was less. We said maybe when I'm standing here, that my brain is a little bit squished down with gravity. Farther away, distance matters, physics matters. It would take less if the brain starts to float back up a bit, right? So we measured it, on the tarmac, pre-flight. Oh, this is back in the lab, on the tarmac, and then while we're floating, and then back on the tarmac. So for some reason, it took less electricity while we're floating, which is interesting. It's feasible to do. You could do this to an astronaut out on the trip to Mars, and it would take less electricity. So good. We're going to have, looking forward, regardless of who's in the White House, we're going to have new treatments that we can do with, and these are the things on the near horizon: suicide effects, alcohol, pain, stroke recovery, adolescent depression, peripartum and pregnancy depression, PTSD, schizophrenia, hallucination. That's my prediction of the FDA-approved treatments for TMS that we will have, I think. Okay, how about me delivering a casserole across my street and learning about more brain stimulation? This lady, unfortunately, has a glioblastoma multiforme, and I walked in and she had a cap on. And she said, this, I have brain stimulation. You must know about that. This is what you do, right? And I looked it up. So the FDA approved treatment is called Optune Geo. It's a wearable, and it is combined with chemotherapy. So it's not standalone. It's only combined with chemotherapy. And you wear it for about 18 hours a day. And it's passing what they call a tumor treating field, which is high energy beams. They're not really beams. It's just electricity going across. So how did this come about? Well, this is the cartoon that when cells are dividing, there's a certain phase in which they're sensitive to the electric fields being produced by this, and it stops their division, whereas normal healthy cells that aren't dividing are unaffected by it. And the science actually comes from this paper way back then, and they showed that these intermediate frequency alternating current, 100 to 300 kilohertz, does actually affect cell growth, both in preclinical and then human models. So that's pretty darn interesting. And it'll get you maybe 2 more months of life. Your chances of survival double at 5 years, but they're still very low. So it is making a clinical effect. And they say they've already had over 25,000 patients treated. So it's actually making a big difference, I think. I always say that these brain stimulation treatments don't really cause changes in brain activity. And this gets very interesting in terms of it can actually stop cell division and growth in a therapeutic way here, but you worry. Okay, the last gee whiz thing. With TMS, you can get a twitch. I can put it over visual cortex and I'll see a phosphene. And that is it. And I was so disappointed. I grew up on Penfield where they would stimulate a part of the brain and there'd be a memory, a childhood memory, or a smell, or a bit of music. And, all my career with TMS, I said, this is so disappointing. That's all we can do. Why can't we do more? And why can't, instead of a twitch, why can't we make a fluid movement? Why can't we make things? And everybody's always said, well, Penfield was wrong. Actually, a lot of those things that he described were actually auras, and he was pushing people into seizures. So the fact that he could do it electrically, he was in a pathologic circuit. So that explains Penfield, what I grew up on. But why can't we do it with TMS or sub-seizure brain stimulation electrical? Well, it's the way the brain is wired. And so this paper is in press in the journal. And what they've done here is gone and used optogenetic motor mapping of multiple limbs and then showing how fluid movement is not just from motor cortex, but it's motor cortex extending into frontal cortex and SMA. So it really is an entire circuit activating in a complicated way to be able to produce the movement. I mean, it makes sense, but we've never really seen that before. And so here is what happens if you optogenetically hit the whole circuit involved in a complex behavior. So instead of a twitch, you can see these are, and they've got maps for feeding behavior, for one side, left side, they've mapped it all out. But what I like about this is it seems to show me the future of brain stimulation, where as we understand more about these complicated circuits, we're actually going to be able to get in and produce fluid movements. I mean, I don't know if it's not a ballet yet, but it shows us the path to get there. And why can't we manipulate memories? Well, it's because they don't exist in one spot. They are in distributed circuits. And what's so exciting to me about this paper is it's the beginning of understanding of how we might be able to stimulate in a distributed fashion. So that gives me a chill on my back. So I will, I'm not finished yet. Can I have a second more? Well, I have to talk about the vagus nerve here and you guys are all experts. Vagus is a big nerve going down, and you can influence it through the neck or through the ear. Afferents going back up, go into the NTS, and they release locus coeruleus and norepinephrine. And so stimulate the vagus going up into the brain, you get a norepinephrine squirt. And so there's this whole field of what's called targeted plasticity, VNS dependent targeted plasticity, where you do a behavior and you pair it with a VNS squirt, and the brain pays attention to it and then learns that behavior better than if you hadn't paired it with VNS. And it is such an interesting area. I became aware of it through the work out of Michael Kilgard's group in Dallas, where they, just for fun, they paired it in rats and taught them how to speak English, which is so interesting. They paired it with different English words, and then the rats paid attention to those words in a different way. Shortly after this paper came out, there have been so many studies now where people do paired PNS when they're learning a second language, very commonly Chinese, and it works. It works. And so people are using it to change behavior. And I just pass this out to you because of the work being done here, where people are looking at the efferent parts of the vagus. What is it doing when it's going away from the brain to all the end organs? And this is a paper out of a group in New York where they have a very sophisticated way of stimulating the vagus, which consists of all these different fiber bundles, some of which are coming from heart, some of which are lung. And when I read this, I just begin to say, well, is all of internal medicine of the future going to be nothing but vagus stimulation, where you could stimulate heart, lung? I mean, you can get at all the end organs through vagus, through these sophisticated ways of stimulation. And in Charleston, my wife, a pediatrician, is actually using stimulation of the vagus in babies who've been born with trauma, asphyxia or hypoxia, and can't learn how to suck, swallow, and breathe. And if you can't feed, you can't go home. And so they stay in the hospital forever until you put a G tube in. And the G tube is a terrible thing because it interferes with early childhood development. And so what she's doing is she's bottle feeding and pairing that with TAVNS and getting great results, cutting the G tube need down to 2/3, cutting it by 2/3. So that's my summary, and I hope to see you in Japan if you can make it. Otherwise, thanks, and I'll take questions.
I knew we had to keep the schedule because it's helped me see a much longer history on which this was built and a path forward. So thank you for at least changing my mood this morning. I'll open it for questions. I'm monitoring to the. So Mark, I have a question about some of your earlier work with emotion induction, and then somewhere somehow the field honed in on a area out of the subgenus cingulate, kind of outside of the context of a much larger network that it needed to. And a lot of the work that Saint has been after was, again, to find that sweet anti-correlated spot with that subgenus cingulate. How much do you think that is primarily how TMS is really modulating the and behind the antidepressant response?
So if I understood your question, how important is finding the anti-correlated spot in TMS?
And the bigger question behind it is how critical is engaging the subgenus cingulate?
Yeah. Well, you can think through the scientific studies to answer the question rigidly, and it takes a long time to do human studies like that. The answers may be coming from other technologies. So you're asking the question about TMS, but we now have with ultrasound the ability to go straight out of region deep and turn it down quickly and see what happens. And there's a paper that just came out last week from a group in Utah using ultrasound of bilateral cingulate, where they went in and with good imaging evidence showed that they were at the cingulate and they reduced it metabolically, blood flow, and that was almost an immediate effect of antidepressant. So we're now getting other technologies where we don't have to go through the cortex to get right there. And if we push it down, do we get antidepressant effects? I think the answer is yes. So, so that answers it somewhat. Could it be that when we go cortically with TMS, and are there other areas that we can manipulate that cause changes in depression? I think so. Probably it is. It's not just the cingulate. And so it may be that those data are true. You can just go directly turn off the cingulate and get people undepressed. However, there may be other areas that you can get to that don't involve cingulate that are antidepressant. I think it's more complicated than that, but we just don't know. In terms of the targeting for treatment of depression, it's an open question. We don't have any good studies showing if you do the anti-correlated spot stimulation compared to just a non-spot or a one-size-fits-all like F4, whether there would be any difference at all. One of your brothers, got him Joe Taylor. He's a brother because he's from Charleston, kind of, is at Harvard, and he's doing a study funded to do exactly that, compare randomized depressed patients, do the cingulate anti-correlation, find that spot, and then if not, go to F4, and then compare across those two. He's calling it the SAINT versus the AINT trial because it ain't the anti-correlate. It's a little bit of a poke to Nolan because one of the other, and I'm disappointed in this, the Magnus, the company, won't actually release the formula that the algorithm that they use to calculate the anti-correlated spot. There are a lot of those out there, and so you can do that, but they won't actually publish and release that which they use. And in science, you really do need to be able to exactly do their methods. Otherwise, if there's a difference, they'll say, "Oh, you didn't use our method." So he's doing the SAINT versus AINT. We should have the answer soon. But even with that, there's still going to be a bit of this messiness due to company policy that I don't agree with. Yeah. Yeah.
Follow up on that. I think we're getting better and better at this. That aren't personal. Sequential treatment.
I don't know if that got captured on the Zoom. If I can summarize, you're saying there may be heterogeneity in the actual disease and how it's lays out in someone's brain, and some people may have depression non-cingulate involved or something like that, right? And I think that's true. I mean, I've always said we're, back at the turn of the century, every cough was a pneumonia, and some were bloody pneumonia that was TB, some were productive, and that turned out to be, pneumococcal. I mean, different. We called everything that was a cough pneumonia, and I think it's quite reasonable that we call everything that just makes this circuit a depression, unless it occurs after an event like today, where we call it grief. But I think grief and depression are very linked. But anyway, Yeah, but how would we figure that out? But I do think that might be true. In the DARPA study, we're actually doing fMRI while people are doing cognitive flexibility and then emotion reappraisal. So some of the things that we think are important for you to do in CBT and to get out of depression and what circuits I think are healthy, we're actually showing within each individual which where for them, what part of their brain they're using to do those kinds of tasks. And so we're hoping that that information, as we're doing it for, if there's a non-responder, it's because, oh, look, when they were doing cognitive flexibility, they used it parietal cortex. I don't know, but it may be that, but I think imaging of during the behaviors that get you undepressed may be a way to begin to think about that. You know, in science, you learn by knocking things in and out. And one of the problems with depression is I can't put somebody in the lab and make them immediately depressed. There was something when we were young called the tryptophan depletion. Anybody heard about that? You'd give somebody a diet for a while and then you'd hit them with something else and then they would throw up and then they'd be depressed for the rest of the day. It's messy. It wasn't a really good knock in, knock out. So one of the problems with studying depression is we don't have a way to really manipulate it in and out in the lab. But we're still making progress. Good question. Yeah.
Just two questions from the on Zoom, and then I'll give you the question. So the first one is about the glioblastoma and whether or not there were any published effect on normal cells. Like, do you know what that type of stimulation ended up doing to normal cells as opposed to the glioblastoma cells?
I think it only affects cells when they're dividing. And so in those animal studies, I just read a few last night, they seem to be normal. Too bad if you're a cell that needs to divide while you're wearing that cap, because it would slow those down. But the key that works in glioblastoma is that it's because those cells are so rapidly growing and changing that it slows it down. But I would bet that if there is any normal cell hanging around who needs to divide, it's going to get knocked as well.
And the second question, I'm paraphrasing it, but for the sync trial was a phase log. Did you observe any effect on cognition, like executive control?
The last bit, like what?
Like executive control, like an improved executive control or something along those lines in the cognitive sphere rather than the...
Yes, we're testing those. I don't have them on the slide, but you were the first one that discovered that VNS has a makes you smarter, and TMS makes you smarter. It makes them smarter. This patient spontaneously last week, she says, I feel better than I have in 20 years. And you know, I not only feel better, but I've got the tools now. I'm going to keep working on it. I know how I'm going to stay well spontaneously. So I think she feels more empowered about her ability to deal with whatever life might throw at you, like an election that didn't go your way.
Go ahead.
I'm going to just speak into this, but and I'm looking at you. First of all, thank you so much for your work in this field. I think it's fascinating. I'm someone who's interested in doing TMS in my practice someday, maybe in combination with ECT. The question I have for you, and I figure you are the most appropriate person to answer this, because if not you, then who? There's a number of meta-analyses out there that mention a high sham bias that could potentially be accounting for TMS relatively recently. And I guess my question is twofold. A, what's being done to counter that? Because when compared to other modalities of treatment right now, we can pretty conclusively say it's working. Based on the meta-analyses, I don't have the confidence necessarily to say TMS is definitively working compared to a placebo. And then secondly, how do I explain that to patients, when they would come to practice and I would say, hey, I do TMS at my location, and then they mention the same meta-analyses. What should I be referencing to them as, here's what we know, here's what we don't know, here's why it's still a valued treatment recommendation for you?
Very complicated question, but I try to get at it. So in order to show that anything works, we run it against a sham or placebo. And in depression, especially, you can get pretty high placebo rates depending upon who you enroll in your trial. And luckily, we came along right after the STAR-D work. And Russian colleagues had shown that if you take people who tried and failed only one medicine and put them in a randomized trial, you'd get about a 40–50% placebo response. If you made them fail two, it would drop down to around 15 or 30%. And that's why we required two failed in the OptMS trial, not because we thought it would work better there or anything else. It's just because we wanted to manipulate the sham rate low enough to where we could find something, if it exists, with a sample size of 200, which is all we could afford. So we designed that trial specifically in order to try to get a low sham rate. And if you remember back to the slide, we had a sham rate of only 15%, which was great. But these were massively treatment-resistant patients, outpatient on no meds. And so it was just really good. Now we do all of our studies on meds. And so these patients are already on meds. There has not been as much attention to a rigorous sham like there were in the early days. And so if anybody who's looking at anything says the effect sizes aren't as big as they used to be, it's really because of the design of what we did and who we chose, as opposed to now it's more whoever comes in the door, less rigor on treatment resistance.
Thank you so much.
Yeah, good.
Great. With that, we're gonna stop here. I know Mark is set to meet with a few other folks throughout the day, and he's gonna be in the department. So I'm sure if you have some questions and you run into him, he'll answer. Thank you so much for coming.
Thank you all. Carry your light forward. Do what you can do.
You should just say he's the chair of surgery and one of the MPIs for Reveal. He's the one.
Oh, yeah.
He's the one who identified